morning, and I want to thank the organizers for inviting me to speak about visual fields. I thought this would be very straightforward because everybody in medical school has already figured out the visual pathway, and all good students will have memorized this already, and so you know a hemianopia, where in the brain to look for a hemianopia, whether it's homonymous or it's bitemporal. It's quite straightforward. There is not much more to localize it. So I thought a few things that are worth our attention. First is to understand that anatomically the what is called the retinotopic organization of your visual fields, and to understand that in the brain, the central 10 degrees of your vision is represented by slightly more than half of the primary visual cortex, and the central 30 degrees will be represented by 80% of the primary visual cortex. So as foveate animals, a lot of our brain's surface for vision is taken up really by the central vision. So it probably tells us why if you do a 24-2 or 32 on a Humphrey, you will get a pretty good representation of most of the brain, right? But if you really want to be complete, then you have to test the entire extent of the 160 degrees of your visual field. But think about it, right? That's why the central vision is so very important, and the glaucoma people will just get away with a 24-2 all the time, because that really makes up most of what our perception is. We all know that there are many methods to doing it. Confrontation, there are about as many methods to do confrontation as there are people doing them. The tangent screen, I'm not sure if anybody still does a tangent screen. It's probably useful in low resource settings, or if you're trying to determine if someone is malingering or has functional loss and you're looking for tunneling of the visual fields. So the germ screen we still have one, and my old mentor Barry Cullen insisted that we buy one for the clinic, so I duly put in one, but it has not found that much use. I've used it mainly in the military when I'm screening some of the soldiers for functional visual loss. Kinetic perimetry, the Goldman is still very much useful, and now you have a Goldman kinetic perimetry built into many of the Humphrey perimeters, some of the octopus or the Humphrey perimeters as well, and of course we have our usual static perimetry. We're all familiar with this, as I mentioned earlier. For example, if you see a superior quadrantenopia, you know it's the temporal lobe. Inferior quadrantenopia, maybe it's the parietal lobe, and a homonymous hemianopia, any sort, just tells you it's on the other side. Of course, there are some special ones like the sectorinopia of a lateral geniculate nucleus lesions, typically incongruous. I must say they're pretty rare and hard to find. It's difficult to pick this up. It certainly doesn't really show up on a Humphrey perimetry, and you really only get it when you try to do a good kinetic perimetry. So it's an interesting feature, but quite hard to detect otherwise. Okay, some guidelines that I think are helpful for us to observe. First of all, optic nerve lesions cause visual field defects corresponding to one of three major nerve fiber bundles. I'll show that in the next slide. And they typically originate from the blind spot, and they don't usually respect the vertical meridian. So they don't usually respect. So they may look like they do, right? Lesions at or behind the chiasm, you will get hemianopic defects. If you have a afferent pupillary defect, it suggests that you are in the anterior visual pathway just before the lateral geniculate nucleus. And if you have homonymous hemianopias, the nearer to the occipital cortex, the more congruous the visual field defect. And if you happen to see macular sparing, which I think is really hard to show on static perimetry and typically shows up on very good kinetic perimetry, then macular sparing usually indicates an occipital lobe lesion in the context of ischemia. So I want to spend a little bit more time talking about optic nerve type visual field defects, because we are often called upon to distinguish this from, say, to tell whether this is glaucoma or it is something else. Okay, so as I said, they start from the blind spot, don't usually respect the vertical meridian. They typically affect the papillomacular bundle, the arcuate bundles, and the nasal bundle. Okay? And visual acuity is typically affected if you have something affecting the optic nerve, right? And so look for visual acuity changes, color vision changes, and an afferent pupillary defect. This patient has a inferior altitudinal, it looks like an inferior defect, right? It seems to have crossed the midline. So you say, well, is this an inferior altitudinal defect or not? But then if you do the kinetic perimetry, it really can show you how it respects the the horizontal midline. Likewise, this patient has just a totally black visual field defect on a Humphrey perimetry, but when you do a kinetic perimetry, you see really it's just a large central scotoma. Bear in mind that Humphrey really does 24 degrees of your visual field, therefore everything going wrong in that 24 degrees, if that's the only place it will go wrong, really is just one form of a central scotoma. And there is a very, very nice old study that demonstrates that the utility of the kinetic perimetry versus the static perimetry in distinguishing between what is a central scotoma or an altitudinal defect. Because if you remember the optic neuritis treatment trial, they said, well, it can cause any type of visual field defect. So why did the old books always talk about a central scotoma? It's because those old textbooks were written in the days of kinetic perimetry, before static perimetry even existed. How about these patients, right? They look like, this patient looks like he has a temporal loss on one side and maybe a little bit of loss on the other side. But when you do the kinetic perimetry, then you can really see in that left eye that central visual field, the largely central visual field defect that this patient has. Which turns out this patient had Molk disease. And how about this? Bilateral disc swelling with, well, not very prominent defects. But if you look at this is a patient with papilledema, and so if you can imagine it, then perhaps you can see that in the right eye, the patient has an enlarged blind spot. In the left eye, maybe the blind spot is enlarged, but maybe some scattered non-specific defects. So I put this here to highlight that papilledema can give you almost any type of visual field defect and not just the enlarged blind spot. These are other examples of papilledema where you just see generalized constriction, which I've put there on the 120 degree visual field, generalized constriction of the visual fields, and maybe just non-specific visual field loss, which you can see on the 24-2 visual field there. One very useful tool here is what has been described as the temporal raphe sign, which is something you see on the OCT. And so if you have a superior nasal visual field defect, that's the top row of this series of pictures, and you can match that to an macular GC-IPL thinning that respects the midline, the horizontal midline or the temporal raphe, then you most likely have a glaucoma. But in the second row and the third row, again in the second row you have a visual field defect. It looks just inferior and one quadrant, but the macular GC-IPL does not seem to match. So I think what we are learning over time is that one ought to look at the macular GC-IPL besides the retinal nerve fiber layer thickness to help decide what kind of a visual field defect this is. So in brief, have a good physical examination, right? Color vision may help, OCTs help, and then if you have access to electrophysiology, now that is definitely helpful, because if you have just pattern ERG abnormality without a VEP delay, you probably have a macular lesion if it's just the P50 is affected. So I do recommend electrophysiology in cases of doubt. This patient looks like she has a bitemporal hemianopia, and that's how she presented. Actually, she initially presented with as glaucoma and had traps done and cataract surgery done, and then someone said, but the pattern looks a bit bitemporal, and so they sent her for a scan, and the scan, nothing, normal. So we did electrophysiology. Then we looked at this and said, but her macular GC-IPL is all completely thinned out, but her nerve fiber layer is still relatively good. So something else is wrong down here. It's in the, when you do the autofluorescence, and you can see the hyperautofluorescence, and it's in the retina, and she has a photoreceptor abnormality, diffuse photoreceptor abnormality. So don't forget the electrophysiology, it is your friend. So finally, just consider doing more than one type of visual field testing. If you have hemianopia, it needs neuroimaging. Do the OCT macular, RNFL and GC-IPL to cross-check and entertain a healthy suspicion if fields and OCTs don't match. And don't forget our friend electrophysiology. Thank you, and I'm